Thank you for the introduction. I will speak today about first trimester ultrasound. That is obviously not a novel feature in prenatal screening, but I will try to propose you a new approach on this topic. The first trimester ultrasound screening is currently one of the main cornerstone in the screening policy during pregnancy. But during the past few years, there have been several changes with the emergence of NIPT, huge technical improvement in ultrasound equipment, and the better understanding of fetal embryology and echo anatomy. A recent review by Jehan Karim shows us that with the use of a standardized and detailed anatomical protocol, we can increase the sensitivity of this exam in a large proportion. Another recent study by Petuzis that follows strictly the usual guidelines for the first trimester ultrasound screening detected 47% of major congenital defect and 36% of major cardiac defect during the first trimester. One could find this a little bit disappointing, so we therefore thought, why not propose a new protocol, another one, but with a new vision, with updated data on the literature and adapted to daily practice. So in this sense, we have conducted a systematic electronic search and search on bibliography reference using mesh term and keyword related to first trimester screening of structural and chromosomal anomalies. Quality assessment of these studies was assessed by the CADAS2 tool. And owing to the heterogeneity of all the studies included, case report, case series, case controls studies, random control mass trial, meta-analysis review, we decided not to conduct meta-analysis with poor sensitivity, but just a descriptive review and analysis. So detection rate, sensitivity, specificity, false positive rates, reproducibility, feasibility were retrieved from the review. You can have here a quick and short preview of one of the big table which was created for the occasion. It's for the heart, with the first column the anatomical area, the second column the defect what we're looking for, the third column the all ultrasound sign, and the fourth column the plane that are used to analyze. And after you have the detection rate, feasibility, reproducibility, the classification, I will talk to you about it later, and the bibliography reference. Ultrasound sign was then classified into 3 priority step categories according to the screening performance. If the detection rate was above 80%, it was classified as mandatory, between 50 and 80% as useful, and under 50% of detection rate optional. Every ultrasound sign illustrated by an echo anatomy schema, and every view was summarized in a comprehensive and schematic illustration. If an ultrasound sign was categorized in the mandatory classification, it was automatically included in our protocol. In case of useful classification, it was included only if the author, us, judged it essential for the protocol and according to predefined criteria and after consultation. And if the ultrasound sign was classified as optional, it was not included in the protocol unless the corresponding view was already on the list. It was then included, but with a lower priority assessment. We retrieved 150 publications among more than 4,000 papers for this systematic review. A total of 64 ultrasound signs were identified in the screening of 43 fetal or placental anomalies. 11, 13, and 14 signs, respectively, have been classified as mandatory, useful, or optional. And a total of 18 views were described to obtain all these ultrasound signs, from which only 12 views met our inclusion criteria for our standardized protocol. You can have a glimpse of all the 12 views on the right side of the slide. Nuchal translucency and crown rump length views were the most informative views, with respectively 13 and 10 ultrasound sign described. You can have on the right side of the slide a glimpse of the schematic illustration that we made for every view, every ultrasound sign in this review of our protocol. You can imagine this protocol as a toolbox which can be used by every physician and according to their skills, ultrasound equipment, population studied, and actual learning curve. You can see in this example of the limb deformities ultrasound sign that we have tried to be very precise between screening and diagnosis, despite some often blurred border between the both. In conclusion, we have achieved to build a standardized protocol that we think can optimize first trimester detection of fetal defects by introducing a new paradigm with a priority step classification. You can imagine this as a toolbox. We, of course, have a main concern about either setting versus real-life practice. We are aware that theoretical feasibility is sometimes very far away from daily practice clinic. This is highlighted by this quality assessment with the CADAS tool, with a high concern regarding applicability of the index test on the right side of the slide. Learning curve, teaching, and quality control program are keywords in this topic. And obviously, future research will be mandatory to assess feasibility, reproducibility, positive predictive value, negative predictive value, and detection rate of this protocol in routine practice. So we need you. Thank you for your attention.